Should we start? Anjali, should we start?
Yes.
Yeah. A very good evening, one and all. It gives me a great pleasure while I extend a warm welcome on behalf of MCR, that is Maharashtra College of Radiology, and Fujifilm in this webinar lecture series. Finally, the wait is over. It was our MCR members and our MCR chairman, Dr. Sanjay Desley's dream to invite sir on this platform. We all welcome you, sir. Guru Brahma, Guru Vishnu, Guru Dev Maheshwara, Guru Sakshat Parabrahma Tasmait Sri Guruve Namaha. Sir needs no introduction because he is Guru of Gurus and he is God for people like us who love the fetus. So without wasting much of your time, let us get started with the lecture. I request sir to come on the dais and share his screen. Thank you, sir.
Thank you very much, Dr. Manjusha, and thank you, the MCR group, Dr. Sanjay Desale, my very good friend. Thank you for arranging this meeting this evening. And the topic that we're going to do is the overriding artery in congenital heart disease. So before I start off, I will share my screen. Okay. I will have to be enabled, please, the host to enable me to share the screen. Kindly enable me to share the screen, please. The
Anjali,
host.
please enable screen sharing.
Okay, is my screen seen now?
Yes, sir.
Okay, just a minute. I will push this and I will go and hide the screen. Hide name, hide video panel. Hide controls. Let me see. I just don't want that. Hide floating. Yep. Okay. Okay, is it full screen now? Hello, is this full screen? Yeah.
Yes, sir. Yes, sir.
My arrow is moving.
Yes, sir.
Okay, so we'll get started. The idea is to look at the situation of the overriding artery. As all of us know that the two ventricular chambers are connected to the two great arteries, the left ventricle to the aorta and the right ventricle to the pulmonary artery. But if there is a problem in the conotruncal embryogenesis, then we will have one artery which can override a malaligned VSD and it can be committed to both ventricles. When we look at a finding like this is only a finding. How do we arrive at the final diagnosis is the gist of this presentation. Okay, a bit of embryology. We all know that the conotruncus is divided by a spiral membrane into an anterior aorta and a posterior an anterior pulmonary artery and a posterior aorta at the origin. Now, this spiral septum progressively grows downwards and ultimately meets with the interventricular septum, the rest of the interventricular septum. if this spiral septum is displaced anteriorly or posteriorly, then you will have the situation where one half of the truncus, which is going to form the pulmonary artery, will be narrow, and the posterior artery will be big if there is an anterior displacement. And I have a slide to explain this. So the gist is anterior or posterior septal displacement results in failure of fusion. This is malaligned. If this septum goes anterior or posterior, it will not meet with the rest of the interventricular septum, and that results in a malalignment VSD, which I have used the term MVSD. Now let's look at this, the common arterial trunk, and that is the spiral septum. So it is spiral, and because it is spiral, ultimately it results in the great arterial crisscross. If the septum is not spiral, and if it is just straight, you will have parallel arteries. You will not have the crisscross. So that is basically what the septum does in the area of the conotrungus, right? So now let us look at the anterior displacement or anterior placement of the spiral and conal septa. So if it is, this is anterior, this is posterior. Posteriorly, you have the, this is anterior. You can see the blue line, and that is the pulmonary trunk. And behind is posterior. So if there is an anterior displacement of the septum, naturally the pulmonary artery will be narrow, and that space will be allotted to the aorta. The aorta becomes big. So which is the artery which is likely to override the crest of the malalignment VSD? Naturally, it is the aorta. So therefore, you will see that the interventricular septum, as you see from the aorta, from the truncus above, the septum is displaced anteriorly, giving rise to a narrow pulmonary artery, a larger aorta, and the aorta begins to override the crest of the malalignment VSD, right? So therefore, here with an anterior displacement, you get a smaller pulmonary artery and a larger artery, which is the aorta. It is generally the larger artery which overrides the malalignment septum. Similarly, if the septum were to be posteriorly displaced, you would get a larger pulmonary artery and a smaller aorta, and the pulmonary artery would override. So that is, very simply speaking, the understanding of why one artery overrides and is large, why the other great artery is narrow, and this is a simple way to understand, right? Just a second, let me hide this, yeah. Okay, so the great artery overriding happens only if there's a malalignment VSD. If there is no malalignment, there is no overriding. And these figures are very explicit. You will see that if the aorta is arising from the left ventricle and there is no malalignment VSD, then the aorta is committed only to the left ventricle. Here what has happened is there's a membranous VSD, but there is no displacement, there is no malalignment, and therefore the aorta is still committed to the left ventricle. Whereas if there is a malalignment VSD, this, remember, this is only a perimembranous, this is a malalignment VSD. Because of the malalignment, the pulmonary artery is smaller this side, the aorta is bigger, and it overrides the crest of the VSD. And therefore, both ventricles begin to pump blood into the aorta. So this can happen, the overriding can happen to the aorta or to the main pulmonary artery, Okay, so hemodynamically, what does it mean to us? it means that the aorta is committed only to the left ventricle in situation 1, that's normal. In situation 2, the aorta is committed only to the left ventricle, but the left ventricle also shoots out blood and perhaps receives blood to the right ventricle or from the right ventricle through a bidirectional flow through the VSD. Whereas if it's small aligned, you will have both ventricles which have access into the aorta, and therefore aorta is committed to both ventricles. So that is the hemodynamic implications. Now let us look at what is this malalignment and how do we actually look for it on ultrasound. Now first I'm going to play a clip which shows us a normal LVOT. And this is a clip which shows us, I've started from the 4-chamber view and quickly I've turned into the LVOT. All of us are very familiar with this. So let me take the bookmark here and you will see that there is an aortoseptal continuity, which we all know is one of the major findings or major points in the checklist that we do when we study the LVOT. Right, so that's normal. That's absolutely normal. Now let's move to this clip. Are the clips playing smoothly, Dr. Manjusha? Are the clips playing smoothly?
Yes, sir. Yes, sir.
Okay, good. Okay, so let's look at this clip, and in this, I want you to see the aortoseptum in terms of continuity, and all of you will agree that there is a discontinuity here, but although there is a discontinuity, there is no displacement of the aorta to override. The collinearity is maintained. You will see that the anterior wall of the aorta is still collinear with the interventricular septum in spite of this defect, and that is classically a membranous VSD or a perimembranous VSD. On the other hand, let us look at this clip. And here you will see that the aorta has overridden the spine, the crest of the septum is here. This is the aortic root, and the aorta is clearly overriding the malaligned VSD, and therefore both the right ventricle and the left ventricle are pumping blood into the aorta. So we look for the overriding of the aorta basically in the 5-chamber view and in the outflow tract, specifically in the LVOT version of the outflow tract. So therefore, that's normal. That's a perimembranous VSD, and this is a mal-aligned VSD, which is always associated with overriding. So you can talk of it in the same breath. All alignment VSD and overriding are nothing but the same entity. Remember, this is a finding. This is not the final diagnosis. So you can't say in my report, I cannot say I have seen an overriding artery and full stop. That is my diagnosis. It is not a diagnosis. It is a step to diagnosis. It is a part of the other findings, which when taken in totality will give you the diagnosis. And also, this is a good view to look at the degree of override. Here, if you look very carefully, more of the right ventricle, the aorta is more partial to the right ventricle. Remember, this is the spine, this is the sternum, this is the anterior chamber, the right ventricle, posterior chamber, the left ventricle, the interventricular septum, and this is the mal-aligned VSD here. More of the right ventricle is committed to the overriding aorta or artery, whereas less of the left ventricle is committed to the overriding artery. So that is important because as we move on, we will know how this feature helps us to differentiate between tetralogy of Fallot on one side and a DORV TOF type or tetralogy type on the other hand. Now, another important thing is this is a normal LVOT. You will find that there's an obtuse angle between the interventricular septum and the aortic components of the aortoseptum. So therefore, you will see that this is an angle. There is an obtuse angle. On the other hand, if I were to look at a case where there's an overriding malaligned VSD and an overriding aorta which is committed to both ventricles, you will find that this angle is missing. This angle is missing. So this will help in very subtle cases. Sometimes an overriding may not be as great as this. You will catch it in a particular angle, in a particular fetal position, but not in other fetals. So it can be a challenging situation to actually look for a malaligned VSD and overriding when it is a subtle finding. But even when it is subtle, you will find that this collinearity will help you to suspect it. That obtuse angle that you see normally is gone, and you get a collinearity, that is a straight line arrangement between the middle of the aorta, ascending aorta axis, and the interventricular septum. So whenever you find an overriding artery, and as we know, most often we find the overriding artery when we move from the 4-chamber view into the LVOT or into the 5-chamber view. Either of these can give you, but believe me, a rotational LVOT would bring out the overriding the best, right? So once you see an overriding, you need to get to your final diagnosis. That's just the beginning. It may be only the lead finding, and the lead finding should stimulate one to do an entire echocardiography and get at the final diagnosis. And what questions that we're going to pose to actually look at or solve this problem which has occurred in the outflow tracts, right? So the question number one I'm going to ask is, there is one overriding artery. Is there a second great artery arising from any of the ventricles, right? First question. Secondly, the overriding artery is there, but what is the nature of the overriding artery? Is it the aorta or is it the main pulmonary artery? Aorta if the overriding artery arches, or main pulmonary artery if it divides in the axial plane. What is the size and blood flow direction in the great arteries, right? We know the overriding artery is big, the other artery is small, and we need to study the blood flow directions in the great arteries. What is the relationship of the great arteries? And lastly, as I said a little while ago, what is the degree of override? Which ventricle is being favored? Is the right ventricle pumping? Is the aorta more committed to the right ventricle or more committed to the left ventricle? So these are the questions which will enable you to answer what is happening in the conotruncal area, the outflow tracts. But we also should remember that we need to do the sequential segmental analysis, which means we need to go from all the planes starting from the upper abdomen. We need to look at the arches. We need to look at the trachea. We need to pay attention to the thymus to get at the whole diagnosis. These 5 questions help us to solve the conundrum or the problem or the puzzle which the overriding artery has put in front of us. So we will go through the very simple algorithms. We will go through each of those questions. The first question we said is presence of a second great artery, right? You can recognize this on grayscale. You can recognize this on color. Or, of course, you can recognize it if you use a high-frequency transducer. If the patient is thin, and I very, very strongly recommend use the highest frequency transducer, which the build of the patient allows you to use. Because once you use a high-frequency transducer, your job of recognition becomes that much easier. Okay, so when you look for actively, there is an overriding artery. Let me go up and down. Let me go from 4-chamber view to LVOT. Let me go to the RVOT. Let me move to the 5-chamber view. So use your rotational skills and use your up and down, a translatory movement to see if there's a second great artery. And a great artery is a great artery only if it comes from a ventricle, right? So if there is another great artery, yes, if there is, you're unable to find it both by grayscale, color, high frequency, whatever, no. So in which are the two conditions where you don't find a second great artery? Pulmonary atresia and VSD type 2 and common arterial trunk. Whereas if there is a second great artery, you would think of a tetralogy of Fallot, a double outlet right ventricle, or an interrupted aortic arch type B, which is the most common. So that is as far as the second artery goes. It's easy to understand because if the aorta is overriding and the pulmonary artery is atretic, pulmonary atresia with VSD, that means the pulmonary artery is atretic, you may not see it at all. It may be just cord-like, right? Or if the pulmonary artery is arising from a common arterial trunk, then it is not arising from the ventricle, so you can't call it a great artery, isn't it? Whereas in all these conditions, you do have a second artery, and the second artery generally is a narrow artery, with the exception of interrupted aortic arch, which we will come to a little later. The next question is identify the overriding artery. An overriding artery can be either the aorta or the pulmonary artery. And how do you say it is the aorta? If it's an arching artery. How do you say it is the main pulmonary artery? If it is bifurcating. If it is bifurcating in the axial plane, a property or an attribute of main pulmonary artery, and an artery which arches is the aorta, right? So where do you think the aorta arches? It can arch in, where do you think the aorta is overriding? DOF, DORV, PAVSD type 1, interrupted aortic arch. And here, where do you think which condition do you think the main pulmonary artery is overriding? Classical example is DORV. Remember, DORV is not one condition. There can be 33 combinations and permutations, which can give rise to 33 types of DORV. So you can get a DORV where the overriding artery is main pulmonary artery, in which case the VSD or the malalignment VSD is subpulmonic. And if the aorta is overriding, you call the malalignment VSD as subaortic malalignment VSD. So arching or bifurcating will help us to differentiate the nature of the overriding artery. Now, what about the size of the great arteries? Aorta could be greater than or equal to or lesser than the main pulmonary artery. The overriding artery is generally large. As a rule, it is large. And if the overriding artery is the aorta, you have a large aorta in TOF, PAVSD, and DORV, certain types of DORV. If the main pulmonary artery is the overriding aorta, you can have it in certain varieties of DORV. And if truncus is the overriding aorta, your answer is common arterial trunk. So the overriding artery can be large, and this large artery could be either the aorta, main pulmonary artery, or truncus. And we'll see examples in flesh and blood of all these conditions, right? If the overriding artery is small, there are only a couple of conditions, that is interrupted aortic arch type B and DORV, where there is an aortic stenosis. So remember, DORV is associated with outflow tract stenosis, pulmonary or aortic. If the aorta is stenotic in DORV and it is overriding, you will find that the smaller artery is the overriding artery. And MPA can be an overriding artery in DORV. As I said, you can get any combos. So DORV is ubiquitous. It can come in any of these categories. So overriding artery, large; overriding artery, small. Remember, overriding artery small is much rarer than overriding artery big. and it is seen in interrupted aortic arch when the aorta is in question. And in DORV, it could be either a small aorta or a small pulmonary artery, which is overriding, and we'll see examples of this. So what is the relationship of the great arteries? The relationship, luckily for us, is only two, is either a crisscross or parallel. Crisscross is for all of these, and parallel is only for DORV. And again, notice the fact that DORV comes in both the categories, and that shows the heterogeneous nature of DORV. It is not one kind of a relationship of the great arteries and of the overriding and of the calibers that we see in DORV. So crossover and parallel. So these are the questions that we must answer. And when you turn the color Doppler on, what is the blood flow in the second artery? In the overriding artery, it's easy to understand. It is committed to both the ventricles. The ventricles are pumping into it. It has to be antegrade. But in the second artery, it is antegrade in TOF, DORV, in interrupted aortic arch, but it is retrograde in pulmonary atresia with VSD type 1, right? So therefore, whenever the pulmonary artery is atretic, then you will have a reversed flow into the pulmonary artery through the ductus venosus, right? So what about favoring one ventricle over the other? If the left ventricle is favored by the overriding artery, as happens in TOF and in interrupted aortic arch type B, or you can have a right ventricular favoring, as can happen in double outlet right ventricle. After all, what is double outlet right ventricle? By definition, it is when the right ventricle supports more than 1.5 of the great arteries. So one great artery, it has supported, yes, the pulmonary artery. The other great artery, which is overriding, the aorta, which is in question now, is more committed to the right ventricle than the left ventricle. So the right ventricle, in effect, will be supporting one full great artery and more than half of the second great artery, therefore meriting the diagnosis of DORV. So we will, when you see all the pictures, all this will come to life and you will understand. So we'll start with the case scenarios. And again, I want you to see this clip very carefully. Now here, the first question I'm going to answer is the second great artery there? One great artery I can see, and the first thing, even before the second great artery, I'm going to determine, does it look to be dividing or arching, right? This is naturally an arching vessel, and therefore I'm going to say that this big artery is the aorta, and the aorta is the overriding artery. You can see both the ventricles are committed. And is there a second artery? Yes, I draw your attention to this chamber, which is the right ventricle. This is the spine, substernal right ventricle, and you see a second artery which is coming in this fashion. Right? The second artery, so we have already finished answering the overriding artery looks to be the aorta. And I want you to see what is happening to the second artery, which is narrow, which is coming from the substernal right ventricle. What is happening to it? It is dividing, and it's dividing in the axial plane. So this has to be the pulmonary artery. The pulmonary artery also, you will realize very, very easily the fact that the pulmonary artery is dividing. So you can see the division there. And lastly, I just want you to look at the relationship of the ascending aorta and the pulmonary artery. There is a crisscross. The arteries are mutually perpendicular to each other. And to look at some bookmarks, the first bookmark takes us to the narrow pulmonary artery. The second bookmark takes us to the overriding aorta, committed more to the left ventricle, less to the right ventricle. And also the third bookmark, a very important bookmark, showing us not only the bifurcation of the pulmonary artery, narrow pulmonary artery. That is the trachea. And I just want you to see the trachea and its relationship to the overriding artery. This is situs solitus. This is left. This is right. So the arching artery is going typically it is going to the right of the trachea. So you have a right aortic arch, right? And also I'm used to the pulmonary artery, which is communicating with the descending aorta to form the ductus arch. Yes or no? This is a descending aorta. But I'm showing you the entire clip up and down. Do you find the pulmonary artery extending all the way and coming here to the ductus arteriosus? No, it is dividing. There is nothing, no ductus connecting the main pulmonary artery to the descending aorta. I hope this is clear, and therefore I'm going to diagnose a ductus arteriosus agenesis. So since there is an overriding aorta and a narrow pulmonary artery, I'm going to diagnose tetralogy of Fallot with a right aortic arch with a ductus arteriosus agenesis. Now, in this scenario, would you use color? Yes, I want to use color, especially to see the second artery, not the overriding artery. As I said, overriding artery is a forward flow, whereas I need to see the artery which is smaller. So let's look at this clip. I have turned the color Doppler on. This is an apical LVOT, and you find that both ventricles are pumping blood into the large aorta, right? Very, very well seen. And you will see that in this clip, when I come to this, that is the overriding aorta, you will also see a bit of the main pulmonary artery fleetingly coming here, showing you blue again. So I'm concentrating on that in this particular clip. Let me stop this. You will see that that is the main pulmonary artery coming from the right ventricle, which is narrow. And needless to say, you know that this is also forward flow. If that were to be reversed flow, if that was coming in red, I would think of pulmonary atresia. But remember, pulmonary atresia is ductus dependent, and therefore the ductus would have been there in that. In this, of course, the ductus arteriosus is absent. So your total diagnosis is tetralogy of Fallot with a right aortic arch and with a ductus. We know the ductus arteriosus agenesis. And also color helps you to earmark the aorta going to the right of the trachea here. So it's a right aortic arch. So that is how you answer those 5 questions. You have got your final diagnosis. Now from there, we move on to another case scenario. And I want you to see this particular case. So the first thing is 4-chamber view, and then quickly it goes into the LVOT. And in LVOT, you have the all familiar pattern of the overriding artery. The overriding artery, which looks quite big. Now, in this background, I need to look at the RVOT, and I'm doing the 3-vessel view version of the RVOT. So you have the aorta here. You have this is the right side, this is the left side, and you have the IVC, SVC here coming and going. You have the aorta, you have the pulmonary artery. The pulmonary artery arises from the substernal right ventricle, goes directly posteriorly. But what are your findings here? The annulus of the pulmonary valve is narrow, but soon after that, there is bifurcation, and the branch pulmonary arteries are dilated. And also the fact that I am not seeing a ductus arteriosus connecting the main pulmonary artery to the descending aorta. So I see a narrow annulus and a dilated branch pulmonary arteries. Naturally, I am quite curious. And is there a crisscross? Definitely there's a crisscross. Why is that? Because this is the long axis of the pulmonary artery is matched with the short axis of the aorta. So if the long axis of one artery is matched with the short axis of the other artery in the same plane, these two arteries must be mutually perpendicular. Simple. It's just a spatial concept which all of us have to recognize. So let me stop this clip, and then you start the Doppler. When you put the Doppler, color Doppler, when you bring your color box in, you will find that there is the flow is blue in during systole. And when it is blue, you get a lot of aliasing which is happening there. So let me take you there. That is the blue, which is a normal flow direction from anterior to posterior, but there is aliasing telling you that this is a stenotic valve, the pulmonary valve, right? But also when you see another phase, that's the diastolic phase, you find that there's a regurgitation. So therefore, this pulmonary valve is as good as useless. A valve is meant to regulate flow in one single direction, right? But here that valve is not doing its work because there's a to and fro. You see a blue and red, and this is classical. And look at the helical flow seen in the dilated branch pulmonary arteries. So branch pulmonary arteries are dilated, to and fro flow across the pulmonary valve, a heavy aliasing seen during systole, telling us it's not only stenotic, but stenotic and regurgitant. And you will see the same in the long axis RVOT. You see the regurgitation, which is seen very well, and on spectral Doppler. So therefore, this is a classical absent pulmonary valve syndrome. Absent pulmonary valve syndrome. And also, again, note that there is no ductus arteriosus connecting up the pulmonary artery with the descending aorta. So your diagnosis is absent pulmonary valve syndrome or absent pulmonary valve, as well as a ductus arteriosus agenesis. Here again, we answered all the questions. It's the arching artery is the overriding artery. The pulmonary artery is committed totally to the right ventricle. And of course, the valve tells us that it is stenotic on scale, and it is stenotic and regurgitant on color. The ductus arteriosus is not seen, and therefore, again, your diagnosis is absent pulmonary valve with ductus arteriosus agenesis. So here we saw two cases where the crisscross was present. The great arterial crisscross was present. And of course, in one case, the pulmonary artery was narrow, as in DOF. And in the other case, the pulmonary valve was narrow. But soon after that, the branch pulmonary artery became dilated, classical signature of absent pulmonary valve syndrome. Now let's look at this particular case and answer the first question. First of all, is there an overriding artery? Yes, there is an overriding artery, which is really big. Just like in the previous case, this also is a huge, and in fact, it is much, much more bigger than the previous case, very markedly big, right? And it is overriding the crest of interventricular septum, almost equally committed. This overriding artery is almost equally committed to the overriding artery in terms of both chambers, right? The valve, if you notice here, is normal or abnormal. And a semilunar valve, when it closes in diastole, should be very thin and diaphanous, so thin and diaphanous that you see only that central spot where all the three cusps of the semilunar valve are meeting. But here you see that the valve is thick. Why? Because you can see in diastole that the valve is seen throughout as a thick frayed structure, right? In my quest or in my efforts to look for a second artery, as I'm going from the four-chamber view into LVOT, four-chamber view into the five-chamber view, translatory movement, rotatory movement, I suddenly find a smaller artery coming from this big artery posteriorly. So that to me could be the pulmonary artery. That to me could be the pulmonary artery. And what should I show of this artery to nail it and say that this indeed is the pulmonary artery. This is easy for me. This is arching. The great arteries are coming from here. So this is the aorta. But the pulmonary artery is also arising from the same segment of the artery from which aorta has come. So if this is the pulmonary artery, then that part of the anatomy becomes the common arterial trunk. As soon as the common arterial trunk comes out of the ventricles, it divides into a large, very large and prominent aortic arch and a smaller pulmonary artery, which I said you have to identify. So now our job is done. There is no second great artery because a great artery is a great artery. If the pulmonary artery had come from the ventricle, it is not coming from the ventricle, it is coming from the aorta, it is coming from the common arterial trunk, and therefore this is the pulmonary artery, which does not merit to be called. Technically, it doesn't become a great artery. So now what I'm going to do, I'm going to compare the aortic size to the MPS size. It is very, very large aorta compared to the narrow pulmonary artery. The crisscross is irrelevant because it's not starting from the ventricle. And of course, as I said, equal committance of the overriding artery. So now if I were to call this the pulmonary artery, I must rotate the transducer and try and get other views. And the first view I get when I go axial, this is oblique, LVOT is parasternal oblique view, this is axial. You find that this is the common arterial trunk. That is the truncal valve, which is abnormally thick. That is the aorta, which is larger caliber. This is the pulmonary artery, which is smaller caliber. And when I do a little real-time exercise, you find that this is the aorta, posterior course of the pulmonary artery, main pulmonary artery. And what is happening to the main pulmonary artery? Or let me say artery X. Artery X is dividing into the right and left, in each one going to the respective lungs. So the fact that it is dividing tells me that this indeed is the pulmonary artery, is arising from the common arterial trunk. Your diagnosis is CAT type 1. And would you do a Doppler? Yes, you would do a Doppler just to show the fact that the main pulmonary artery is taking blood in the antegrade direction, and also it gives you a chance to show the bifurcation very, very easily. So these are the two reasons why I will do a Doppler of the great arteries. And notwithstanding that, I will also look for truncal regurgitation, because truncal valve is a dysplastic valve. That is why it is thick, and when the valve is dysplastic, it can regurgitate. Now let's move on to the next. And going on with the same case, remember, this was a CAT type 1. In the same case, you will find a ductus venosus agenesis, and you will find umbilicosystemic shunt, the umbilical vein going all the way up, going over the liver and draining into the IVC just before the IVC gets into the heart. So that's an umbilicosystemic shunt, DV agenesis. Most probably the portal circulation is not there. The intrahepatic portal system is not there. And also when I try to look for the stomach is not getting filled. When I go into the neck, I see a proximal dilated esophageal pouch in the neck. So associated anomalies of ductus venosus agenesis, and of course an umbilicosystemic shunt and esophageal atresia. So we've got to look for associated abnormalities in such cases. Now let's move on and let's look at this case now. So here you find a 4-chamber view to start with, and the 4-chamber view looks rotated. Let me play the clip. Looks a little rotated, a left axis rotation, and then I move into the LVOT. You find a classical overriding, and this is an arching aorta, right? Is there a second artery? That we will have to sort out. And in the same clip, I want you to see that there is a second artery, which is a little tortuous. I'll play the clip for you. So there is indeed a second artery. There is indeed, yes, there you are. This is the big artery overriding and of course the arching. So you know the overriding artery is arching. Now let's go to this clip on color, and you can see that this is the overriding artery, which is really large and huge. That is the aorta. This is the SVC. This is the trachea, which is happening. Yeah, that's the trachea. And you see that there is a second artery, which is coming from the ventricle. So the great artery is there. A second great artery is there, and it is much, much narrower, trying to come from the right ventricle. But when I turn the color Doppler on, here is the surprise. Instead of this being blue, that is being perfused by the ventricle, it is getting supported by flow through a tortuous ductus in the reversed fashion. Immediately telling me that this is not phallostetrology, this is a pulmonary atresia with a VSD. A pulmonary atresia. Why? Because only if the pulmonary artery valve is atretic, you will not have blood getting pumped antegrade. The blood will be fed to the pulmonary artery thanks to the patent ductus and thanks to the blood flow from the huge aortic arch, which is now going to go through the ductus and reverse perfused. So this is a PAVSD, and here we realized, we identified the great arteries correctly. We said that the pulmonary artery is narrow. We also said that the great arterial crisscross is there. That is the aorta. That is the pulmonary artery. Crisscross is there, or everything trying to fit into TOF. But when I turn the color Doppler on, you find the reverse flow, and that opens my eyes. Oh, it is not TOF, it's a PAVSD. And in PAVSD, again, a classical finding is a ductus which is tortuous, and that is a tortuous vessel that you see here. Ductus arteriosus is tortuous in cases of PAVSD. So that's PAVSD type A. Why type A? Because it's a reversed ductal filling, ductus dependent filling of the pulmonary artery, and the VSD is subaortic. Okay, now here is another case. That is the fourth ventricle. That's the fourth chamber view, showing you the fact that there is a axis rotation. There's a left axis rotation. When I go to the LVOT, you find that there is an overriding aorta that you can see here. Overriding aorta, and you have almost equal participation of both ventricles pumping into. That's the color Doppler, which is telling you the same, right? So therefore, overriding aorta, it is arching and it is equally committed. Now, in this scenario, I want you to see the three-vessel trachea. You find only one vessel, and it's a large vessel. It is a large vessel, just as large as what we saw in the previous case of PAVSD, and just as what we saw in CAT, that is common arterial trunk. But I don't see reverse flow in a pulmonary artery. Whatever I do, grayscale, color, high frequency, anything, I do not see a second artery. Instead, when I do a drop down on my PRF, I find that this is the descending aorta. The descending aorta is giving rise to branches which are directly perfusing the lung. So this is major aortopulmonary collateral supply, or MAPCAS. So here is your type B. I showed you type A. This is type C, rather, where you have direct branches from the descending aorta going into the lung, right? Major aortopulmonary collateral arteries, MAPCAS. That is one MAPCA here. Here is another map curve, that's the descending aorta, and from the descending aorta, you have an arterial branch which is going into the lung. And this is a little bit of 3D, color 3D with glass body, showing you the map curves on 3D. So therefore, here the clue lies in two things. One is the single artery is very, very prominent, and that is seen very well in the, look at this, one of the biggest arteries that we can see here. There is no second artery, both by grayscale and by color. I don't find anything. And in fact, as I'm searching for the right ventricular outflow tract, the Doppler picks up a few map curves, and my diagnosis is fixed. It is a pulmonary atresia with VSD type C, where there are map curves, right? Okay, now we've finished cracking the tetralogy of Fallot, absent pulmonary valve. Then we went on to CAT type 1, and we saw a case of PAVSD ductus dependent circulation, the case of PAVSD with major aortopulmonary laterals, and now we come to DORV, which I said is a bag of exogenous situations depending upon the kind of VSD, whether it's subaortic, subpulmonic, remote VSD, or a doubly committed VSD, whether there's an aortic stenosis or a pulmonary stenosis, so on. So it's a mixed bag, and let us see how to crack this case. The first thing I'm going to show you is an overriding aorta because it is arching, overriding aorta because it's arching. There is also a second artery which is coming from the anterior chamber. So this is the pulmonary artery because it's not arching. This is the arching aorta, right? Now, I just want you to realize the fact that the crossover is there. The ascending aorta this direction, pulmonary artery in this direction. But I will take you to one bookmark. That's the bookmark which I want you to see. The overriding aorta. Is it more committed to the left ventricle, posterior ventricle, that is left ventricle, or the anterior ventricle, this is right ventricle? Clearly, you will agree with me that the aorta is more committed to the right than the left, and therefore more than half of the aorta and the full pulmonary artery from the right ventricle. Therefore, this is not TOF, this is DORV of the TOF type, of the tetralogy of Fallot type. And why is the pulmonary artery narrow? Because of stenosis. And where is the VSD? The VSD is under the aorta. So it's a subaortic VSD. You turn the color Doppler on, you find that both ventricles are pumping blood into the aorta. And of course, when you look at the pulmonary artery, the pulmonary artery is taking blood in the right direction. It is blue, and therefore it's not pulmonary atresia. Therefore, this is a DORV of TOF type, right? And all the answers to the 5 questions are given here. I just want you to look at the distance between the great arteries and the anterior chest wall. There's hardly any gap, which means that there could be a thymic hypoplasia. Also, the fact that the aortic arch is moving to the left of the trachea, so therefore this is not a right aortic arch, but a left aortic arch, DORV TOF type. Now let's go on to the next case, and here you will see that this is the spine, this is the anterior chest wall. You find that there are 2 great arteries, and both of them are majorly the aorta. This is okay. Before we say what is the origin, let us identify the arteries. There is one large artery, and that seems to be arching to me. So I'm going to brand that as the aorta. If I brand this as the aorta, this becomes, the smaller one becomes the pulmonary artery. And you will see that the aorta is anterior. This is the spine. That is the aorta. The aorta is anterior to the pulmonary artery. Instead of pulmonary artery being anterior normally, the aorta has gone anterior. Pulmonary artery is posterior. This is right, this is left. It is not only anterior, the aorta is also to the right of the pulmonary artery. You see a big malaligned VSD here, and I want you to notice the fact that the VSD is under the pulmonary artery. The pulmonary artery is narrow here, the pulmonary stenosis, and this situation is a DTGA type of DORV. Why DTGA? Because instead of crossover, you have parallelism of the great arteries at their origin. The aorta is anterior and to the right of the pulmonary artery. That is why dextro-TGA type of DORV. There is a pulmonary stenosis. That is why the pulmonary artery is narrow, and there is a subpulmonic VSD. Everything put together, this is called the Taussig-Bing anomaly. Taussig-Bing anomaly, a classical description of DORV, DTGA type, and you can turn the color Doppler on, showing you the parallelism over here, and also the fact that the VSD in DORV is a one-way VSD, it's not VSD. So one-way VSD, blood flows from the left ventricle into the right ventricle. So you see only a red coding across the VSD. So that is a classical Taussig-Bing anomaly. And in the same case, you see a right-sided dominance in the four-chamber view, which of course comes later on in the second trimester and the third trimester. And also note that the gap between the great arteries and the sternum is not very much, and therefore I would think of thymic hypoplasia as well. Right, from there we move on. So we finished two cases of DORV. Yeah. You show multiple cases, but I thought I'll limit to one with crossover, that is the top type of DORV, one with parallel arteries, that is the DTGA type, the pulmonary stenosis, subpulmonic VSD, Taussig-Bing anomaly. Now here, this is an interesting case again. You will see that in the four-chamber view, there's nothing much to talk about, but when you come to the left ventricular outflow tract, I will take you to the left ventricular outflow tract. That's the four-chamber view, which looks normal. This is the color of the three vessel. This is the the LVOT. You will find that there's a malaligned VSD. There's an overriding of the vessel that you can see here, but this is a narrow vessel. All along the cases that we saw, only in the immediate last case, that is DORV with pulmonary stenosis, and in this case where the overriding artery on the VSD is small. Otherwise, all the other cases we saw was large. So when the overriding artery is small, you will also have to look for the identity of the artery. So I will wait for this clip to pan out. I will see that the larger artery which you saw was the pulmonary artery, which you can see here. You will see this is the three vessel trachea view. This is the right side, this is the left side. Since it's the three vessel trachea view, the leftmost vessel is the the rightmost vessel is the SVC, and that one next to it is the aorta, and the aorta is definitely small. It is small, right? And I want you to see its relationship in as far as size to the pulmonary artery. You can see that the pulmonary artery is very, very large over here. So this is a total mirror image. Total mirror image. Always aorta was big, and for once the aorta has taken a back seat. It is narrow. It is equal to or even maybe slightly smaller than the SVC. Pulmonary artery is huge, right? And what I'm going to do now is to ask you to see the ductus arch. You can see it very well because it's prominent. I want you to see what is happening to the aorta. If you see very carefully, the aorta is not coming as an aortic arch and joining. It is dividing there. It is dividing there, and those are the neck arteries. So it's a type B interrupted aortic arch. Why? Because there's no aortic arch connecting the ascending aorta to the descending aorta, and the aortic caliber is small. It is actually overriding a VSD. And when you do a color version of the three vessel trachea view, you will see that this is the big pulmonary artery. This is the SVC, and you will see the aorta, which is dividing into the neck arteries, two neck arteries, and it goes away. There is no aortic arch, and this is interrupted aortic arch, type B, subaortic VSD, and perhaps also again with a thymic hypoplasia. Look how close the great arteries are to the anterior chest wall. And when you do a sagittal section, you don't find an arch, you find a straight pulmonary artery dividing and proceeding into the neck. So that's in aortic arch. So remember, in interrupted aortic arch and in DORV, you have an overriding artery which is narrow. These are the only two conditions where it occurs, whereas all the others, the overriding artery is generally the bigger artery. Okay, now let's look at this. Aortoseptal continuity. Now, let me stop this. Let me go there. Again, an LVOT. Let me look at the aortoseptal continuity. There is a discontinuity. Is there malalignment? No, the collinearity is maintained. So maybe a perimembranous VSD. Now let this stay here, and I'll go here. And this is another case. This is another picture done from another angle, apical angle. You find that this is the aorta, this is the VSD, and clearly collinearity here. Both the ventricles have access into the overriding artery, malalignment. So you have normal aortoseptal continuity. Here you have a membranous VSD because of this gap, but no malalignment, and here you have malalignment. Now I'm going to drop the bombshell. I have got all these three clips from the same fetus. So it is very, very important to do multiple angles. You have to take a lateral, you have to take a apical approach, and at some point of time you will find overriding if it is there. Now, what made me do this exercise? The rescue was because of the pulmonary artery. In this case, the pulmonary artery was narrow. And once the pulmonary artery is narrow, you'll think of pulmonary stenosis, but more importantly, you'll think of a tetralogy of Fallot because it's infundibular stenosis. Whereas pulmonary stenosis, valvular stenosis, you might have a little flaring, but infundibular stenosis. And once you think of an infundibular stenosis, you will always think of Fallot, and you will go back, you will spend time doing different axes, different approaches until you are convinced that there is an aortic override, or you have ruled out by all means that there is an aortic override. So it's very, very important, and usually the rescue comes from the pulmonary artery findings, right? So another way of looking at this algorithm is to do in an aortic override is to actually look at the status of the pulmonary artery. So leave alone the DRVs with the pulmonary stenosis and sub-VSD, leave alone the interrupted aortic arch. But if you look at the run-of-the-mill bulk of the cases, in the case of aortic override, let's look at the status of pulmonary artery. If the pulmonary artery is narrow, that is TOF. If the pulmonary artery has large branches, absent pulmonary valve syndrome. If the pulmonary artery is not seen at all, or it is seen narrow and there's a reversed flow from the ductus into the pulmonary artery, PAVSD. If the pulmonary artery arises from the same trunk from which the aorta is actually arising, that is a common arterial trunk. And if the pulmonary artery is narrow and it's parallel to the overriding aorta, that becomes a DORV. So that is a very simplistic way of looking at the role of the status of pulmonary artery in a case of aortic override, which will actually get you closer to your diagnosis. Remember, counseling is important. You will do a KT plus FISH for 22q deletion, or now, of course, we ask for a CMA, because in CMA you can pick up not only deletions and not only the trisomies, etc. You can also pick out micro deletions like 22q11 one deletion. And also you will pull a pediatric cardiologist into the loop for counseling regarding postnatal management. So thank you very, very much for a very patient listening. It's exactly been about an hour. Yes, exactly an hour. I stopped sharing and I open this evening for discussion. Yes, Dr. Manjusha, please.
Yeah. Bhaskar, are there any questions in the chat box?
So far, no questions, ma'am. 1 second, I'll ask admin to look into the questions.
Yeah, because I can't see the delegates
No,
chat box.
the chat, it's not posted in the chat box, ma'am. The questions are going on the other side, not in this chat box.
Yeah. So can you just please have a look?
Till that time, you can ask Manjusha your questions.
Yes, ma'am. So far, there are no questions. Maybe you can have questions from your side.
So that pulmonary artery clue was very, very important, and that's very friendly. I thought that was very simplified way of diagnosing the further anomalies.
I think that's how we learn. Once you find a great one big artery, your next question is, where is the smaller one? Is it there? Is it not there? Is the crisscross there or not? Let me put the color and see if it's antegrade, retrograde. And in fact, I have reduced it to those 5 questions.
Yeah.
That's all I have done. What we do in practice, I have brought it out in terms of a question answer.
Manjusha?
I think Manjusha ma'am has probably disconnected. Is there, ma'am? Is there?
There are no questions on your the other side, the side on which everybody is logged in.
So basically, this time we are using a slightly different version. So I guess they are not able to understand how to post the questions, I believe, sir.
Oh,
yeah. So probably that could
chat,
be.
At least, is there anything in the chat box on the other side?
I am going through the chat box, sir. There somebody has written, but it's a half question. Submembranous VSD is to be. I mean, further they have not written anything on that.
And that's the only question.
Yes, sir. So far, that's the only question.
Is Rachita ma'am also there?
Okay.
Manjusha?
So do you want to tell our viewership to use the chat box to write the questions or to type in? Do you want to? How many people do we have who have logged in now?
They were about 570, sir, last.
570 last. Okay. I don't know. It's surprising that 570 people and there are no questions. I thought there would be plenty of questions.
So I just remember one analogy over here. Sir, I just remember one analogy over here. In a big music concert, sometimes when the maestro is performing, and people just forget to give clap, just forget to give any review or admire. That must have happened today. You know, just there is a huge and that is the biggest reward, I think so. And what prevails is profound joy and serenity. I think that must have happened today, sir.
Nice of you to interpret it in that way. But what I miss is a live audience. I had a set of questions. If it were a live audience, I would have brought in those questions and I would have elicited answers. But on Zoom, it becomes a little impersonal, you know. I mean, at least you are interacting with me. So that is Dr. Desali, and you are interacting. But otherwise, it's largely silence, isn't it?
And whenever you are attending live your sessions and shouting the answer gives so much of pleasure to us, you know. I mean, we are also missing that.
Wonderful.
Anyway, but this was nothing less than a big music concert for us, sir. I mean, that was just great. That was just great. Past 1 hour was, I mean, great concert. Thank you so much, sir.
You called it a music concert. I want you to hum the tune for everybody to hum the tune.
I don't know. I mean, there should be a good end to the music concert, so I should not
venture. Any questions so that people can benefit from our questions?
I think Dr. Manjusha's
sir?
I think it is freezing a little bit. Even hi, Dr. Manjusha. Hi, Dr. Sanjay.
Hello. Hi.
Hi.
You can ask questions so that discussion goes forward.
No, I was just telling Father that even his is breaking a little bit. It's freezing on and off. So I don't know.
Is it only now or through the lecture it was happening?
Through the lecture a couple of times.
No, don't be couple. Couple is only 2 times, no?
Okay, maybe 4.
4 is okay, not bad. Even if it's 4, it's okay.
Actually,
no, it was understandable, even if there was a lag, and after that your voice came in like at a all put together at a very sped up speed. So there were no missed gaps, but it was fine.
Okay, so there we are.
I think Sanjay, should we conclude the thing?
I think you, Rachita, could ask some questions so the discussion goes for 5 minutes so that can.
Anjali Singh in the chat box has said one question I think they've got from the other group: how to diagnose TOF. How to diagnose tetralogy of Fallot.
How to diagnose tetralogy of Fallot? We've seen a case overriding large aorta, small pulmonary artery coming from the right ventricle, crisscross is maintained, antegrade flow of the blood through the pulmonary artery. I think if all this is fulfilled, that is tetralogy of Fallot.
Sir, can you please repeat?
Sir, I want to ask a question.
Yeah.
Hello.
Yes,
so,
please.
At times, it is difficult to differentiate a tetralogy of Fallot from a DORV. Is there any definite criteria? Sometimes it is confusing. So how do we go about it, sir?
Yeah, the overriding artery, the way it is committed to more to the right ventricle or more to the left ventricle is important. Point which I forgot to highlight is, can I share my screen again? I will just share my screen again.
Yes, sir.
Okay, let me go back. Let me go back. Is my screen seen now?
Yes, sir.
Yes, sir.
It is seen. It is seen. Just give me a second. I'm coming up to that case. Okay, I just want you to 1 minute. Let me get rid of this. Okay, I just want you to see this one clip. this one clip. This is what, Dr. Manjusha, what is this valve? This descending aorta, LALV. So what is this valve?
Mitral.
Mitral, anterior leaflet of mitral, correct?
Yes, sir.
I also want you to see what is this valve over here. Overriding aorta. This is what valve? No, that's the aortic valve, because this is aorta, isn't it?
Sir,
Aorta.
Yes.
And I want you to see that the aorta is more committed to
RV.
Yeah, less committed to
LV, left ventricle. Yeah.
Yeah, therefore, this is a DORV. And why I brought this clip back is I want you to see the distance between the aortic valve and the mitral valve.
Okay. Yes,
Normally, the aortic valve and the mitral valve annulus is one continuous fibrous ring. Whereas in DORV, there is an increased aorto-mitral distance.
Okay.
Between the attachment of the semilunar valve here, aortic valve, and the hinge point of the mitral valve. There is a finite distance, which in normal you won't find it. You will not find that in normal. That is another clue. The fact that it is more committed here, less committed to the LV and aortomitral distance is more, right? So those are the clues for DORV.
Yes. So, and one more question. What do you mean by pink fallet?
A pink fallet, the pulmonary artery is not very narrow. It is conducting a lot of blood into the lungs, and therefore the cyanosis is not there in the newborn. It will come later on, but in the newborn it is not there, where the degree of the pulmonary artery stenosis is not that severe.
Yes. Okay, sir. Thank you.
Can you please revise PAIVS, types of PAIVS?
PAIVS. Okay, just a minute, please. Can I share my screen again? Okay.
A lot of people are sending me screenshots of the chat session for the other viewers on YouTube. So I'll read out the questions from the screenshots that they've sent me. There are a lot of questions. We are not able to access that chat session. They're actually manually sending me screenshots on WhatsApp. I'll read one by one once you're done with this question.
Yeah, please do that.
Okay, so here is Sanjay's PAVSD, and this is one of the cases which, 1 minute. Okay, is it seen now?
Not yet. Yeah, now it is.
Yes.
Okay, so this is an axis rotation overriding aorta, very clear, easy. I also see something tortuous here, but I'm not going to mind that now. I'll keep that in the back of my mind. I'll go to this clip. That is the aorta. It's a left-sided aortic arch, no problem. But I see the great artery, the other great artery coming from the right ventricle, which is much narrower. So the first thing I'm going to think is overriding aorta, a narrow pulmonary artery. I will think of colors, isn't it? But when I turn the color on, you find that instead of the pulmonary artery coming in blue, antegrade flow, it is coming in red, which means retrograde flow. That immediately tells me that the pulmonary valve here is atretic. So therefore, this is pulmonary atresia associated with a VSD. So it's PAVSD, ductus dependent type of pulmonary circulation, and it is called type A, right?
Yes.
Now, on the other hand, here is another case of overriding, axis rotation, overriding. But when I do a real time, I don't find a second great artery at all, whether by color or by grade. scale. And when I begin to look for collaterals using a lesser PRF, I find that the collaterals are coming from the descending aorta. You can see that here. So here the pulmonary supply is from the cystic artery descending aorta, and that becomes a type C, which is MAPCAS, which is pulmonary atresia with MAPCAS, major pulmonary collaterals. And this has a worser prognosis. The one with the MAPCAS has a worser prognosis compared to the one which has a dependent reverse arterial failure. Is it clear, Dr. Sanjay,
Yes,
or do you want me
yes,
to
sir,
repeat?
very clear, sir. Thank you.
Okay. I'll now stop sharing. Now you can go ahead with a few of the questions that you have got on your WhatsApp, please, Rachita.
Okay. The first question is distinguishing features between tetralogy of Fallot type of DORV and tetralogy of Fallot. TOF type of DORV versus TOF.
I've just finished dealing with that.
Yeah. And next, can TOF progress to PAVSD?
It can. Lesions can evolve just like you have a aortic stenosis, which can go on to a hyperplastic left heart syndrome. You can have a TOF, which can go on to pulmonary PAVSD, and that is why in a TOF you do a scan at 4 weekly intervals to look at the forward flow of blood in the pulmonary artery, to have a Z score of the pulmonary artery over gestational age, so that you know that it is a stable pulmonary artery or a shrinking pulmonary artery or a pulmonary artery which is actually growing. You would be happy in a TOF, in a case, in a couple who is continuing, you're doing your Z scores at periodic intervals, and the Z scores are maintaining or maybe even improving. That's good news. But if it's closing down and shutting off, that is bad news. It can evolve.
Okay. Which view is better to assess malalignment VSD, apical or lateral?
Both hybrid.
Combination.
Both hybrid. You can go either apical, lateral, hybrid, multiple angles. In different fetuses, you can find it in different angles. And that is what is treacherous about overriding. And that is why I particularly showed you a case where I had produced normal aortoseptal continuity, membranous VSD, as well as overriding on the same heart. Believe me, it's on the same heart. And that is why I use the word, I'm going to drop a bombshell. And all the three I have got from the same fetus. But convincing if you see it from the apical view and you find the malalignment very, very confusing, very, very convincing. On the lateral, it may be convincing if the overriding is very, very gross, but in subtle overriding, you may still need an apical. So it's always a combination. Best answer would be to do a combination. And when do you do it? Whenever there's a narrow pulmonary artery, or whenever the great artery, the pulmonary artery is not seen. That is how I picked up in the case I showed you. The artery was narrow, and that tickled my brains and said, you must look for an override. Then you come back and use all your skills, and at some point of time, you will find it. If you don't find it, you can ask the lady to sit, let her come back, fetus changes position from an apical approach, you can see it. Or if you have done an apical and lateral is not possible, when she comes back, you can do a lateral or a hybrid or a in between, right? That would be the approach.
Okay. Can overriding be evolving?
Evolving, the degree of overriding may evolve, but the act of overriding is said and done during embryogenesis. If there is no overriding at that time, it cannot develop. It cannot develop later on. It is only that the degree, as the fetus grows, the degree of the override might come up. But in a case where it's all said and done by 10 weeks of gestational age, if there is no override, it cannot come later. It cannot come at 12 weeks, 13 weeks, 20 weeks, 30 weeks. No, it cannot. That is the difference between malaligned VSD and VSDs of other kinds. Malalignment VSD will never close. whereas other VSDs have a potential to close. Whether it is perimembranous, whether it is muscular, whether it is inlet, you have a potential, especially muscular, especially perimembranous, they have a potential to close.
Okay. There's a comment
So
that says
I have a
isolated
question.
VSD. Sorry, ma'am, do you want to go? I have a couple of more here.
Yeah, ma'am, you complete, then we'll come.
Yeah,
Isolated
you complete them.
VSD are more so at membranous level. That is, I think, a comment, not a question. Then there is another question. CAT, common arterial trunk type 4, and PA, that is pulmonary atresia, plus TOF, differentiation, sir.
There's no PA plus TOF. Pulmonary atresia is pulmonary atresia. It can't be plus TOF. Isn't it? So it is pulmonary atresia where it's everything what happens, especially PAVSD type A, is everything that you have in TOF except that there's a reverse flow because the pulmonary artery is, pulmonary valve is atretic. In CAT type 4 is a very interesting type because that is a type which has the ductus arteriosus present. Types 1, 2, and 3 do not have ductus arteriosus. In type 4, there are two things which are abnormal. One is in all three types of, first three types of CAT, the aorta is big, the pulmonary artery is small. In type 4, the aorta is small, but the pulmonary artery is big and the ductus is present. So that is how you differentiate. The aorta is small, it is arising from the common arterial trunk, and that aorta will be actually an interrupted aortic arch. So the combination of a large pulmonary artery arising from the common trunk, a narrow aorta, which is interrupted aortic arch, and the presence of a ductus arteriosus are the hallmarks of type 4.
Okay.
I hope that's clear. If I show you a case, you will understand. Yeah.
Okay. Will the overriding vessel always show aliasing due to turbulence?
No, it doesn't. It never shows. It never shows. An overriding artery is generally not the stenotic artery. Remember, an overriding artery is by and large the big artery. The only cases where the overriding artery is narrow is interrupted aortic arch and in a DORV with subpulmonic VSD and pulmonary stenosis. Remember, pulmonary stenosis in TOF, in DORV, and in all the conotruncal abnormalities is not a valvular stenosis. It starts from below the valve, and that is why in TOF and in conditions like DORV, although the great artery is stenosed, it still does not show the classical features of systolic jetting and post-stenotic flaring. Remember, these are features of valvular stenosis. What? And annular narrowing, thick valves, and flaring with systolic and peaking. That is one set which is valvular, whereas in the other set where the narrowing is not valvular narrowing but embryological narrowing due to displacement of the aortopulmonary septum, you will never get aliasing, you will never get flaring, and the valve will never be thick and dysplastic. I hope this is very clear. That is why you don't have aliasing in TOF, although you say that, yes, pulmonary stenosis is there and the pulmonary artery is narrow. Even the case I showed you, there was no aliasing at all. In fact, in my years and years of practice, I've seen only one tetralogy fellow with aliasing. And I don't even show it because I don't want to confuse the audience at all. It's such a rare thing.
In the same context, I would like to ask a question. In these different scenarios, do we take Z-score of vessels at different places? When it is stenosis because of valvular problem at valve level and embryological problem at different level? Z-score measurement and monitoring with Z-score?
Yeah, that's a very good question, because if it is a valvular narrowing, you need to take the Z-score of the annulus. The annulus of the valve in aortic stenosis or pulmonary valve in pulmonary stenosis will be narrow. And you have to take the flared segment also. Because again, what is the why do we take Z-scores? We take Z-scores for two reasons. One is if the couple with the report goes to the pediatric cardiologist for counseling, then the pediatric cardiologist will have a good objective idea of what we have seen. The pictures are there, no doubt about it, but the Z-scores will do the talking better for the pediatric cardiologist to understand the kind of size difference and counsel. That is number one. Number two, if I'm going to follow up a case on a periodic interval, I would want Z-scores, as I said, to know what is happening, whether the annulus is decreasing over time, which is not good, or whether it is maintaining, it is narrow, but growing at that narrow level, which is good. So therefore, you need Z-scores in two places. That is the narrowing at the annulus and the flared part. In pulmonary stenosis, which can occur in DORV, which can occur in TOF, so on and so forth, you would just measure the main pulmonary artery and record your score. I wouldn't do a pulmonary valve Z-score in that instance. Yes.
Sir, how do you counsel a patient with override?
It depends on the diagnosis. It depends on diagnosis. Say suppose it's PAVSD with MAPCAS, then the prognosis is poor. But the idea is that you give all you can to the patient, but counseling, I would love the pediatric cardiologist to counsel, because counseling is not just the surgical details. It is not what is the end point. It is the short-term of surgery, 1 stage, 2 stage, 3 stage. What is the quality of life later on? All this is important. So counseling, although we can do it, if you know the lesion and if you know what is happening, you can counsel. But I always prefer my patients to go and sit across the table, show the report, and get the answers from a pediatric cardiologist.
And genetic workup, chromosomal workup in every override?
Yes, I would rather finish the genetic workup and then send them across. But if on certain occasions we do the amniocentesis and then the patient goes away for counseling pending the results, so it's different. Couples want a different way. So we always do an amniocentesis, send it out for CMA, especially from the microdeletion point of view, especially from today's topic point of view, 22q deletion. Also, we should, whenever we have a case of conotruncal abnormality, especially an interrupted aortic arch, especially isolated aortic arch anomalies like double aortic arch, PAVSD, so on and so forth, in absent pulmonary valve. These are all lesions which can present as 22q deletion with thymic hypoplasia. So look for a wide CSP. Look for facial dysmorphism in terms of a micrognathia or a bleb on the nose. Look for polydactyly. So all these are other features of 22q deletion which one must look for outside of the heart in the fetus to get ourselves closer to a possible diagnosis of 22q11 deletion. But the final answer is by a cytomolecular study.
A few more questions, shall I ask?
What is the time? It's 10:41.
We have time. We have time.
We have time. Okay, then please go ahead.
Okay. Sir, can you explain the role to look for branched arteries in absent pulmonary venous syndrome?
Pulmonary valve syndrome, isn't it?
Yeah, but it says venous syndrome here. I assume it's absent pulmonary valve.
Valve, yeah. Absent pulmonary valve is where the valve leaflets are almost non-existent, and even if they exist and they are rudimentary, they are dysplastic. That is why, although the valve leaflets are there, they don't work. That is why it's called absent pulmonary valve. And since the pulmonary valve is absent, you have forward flow in systole and reverse flow in diastole. And because of this sloshing of blood, high speed sloshing, especially forward flow, because the ventricle is contracting, right ventricle is pushing and pushing blood into the pulmonary artery. So high velocity, and when this high velocity goes there, stenotic jet hits at the branches dilate. It's just like the post-stenotic dilatation of the main pulmonary artery or the aorta, but here it goes on into the branches as well. It goes on to the branches as well. That's why branches are dilated. And another thing which I want to actually ask as a question, I don't know, this is not an on-site program. The biggest overriding arteries occur in which conditions? The biggest overriding arteries. I referred to it in my lecture.
Common
Common
arterial
arterial.
Common arterial trunk and
Absent pulmonary. No, that
no,
was
no,
not over.
no. The largest overriding arteries occur in common arterial trunk where the trunk overrides, and in PAPSD where the aorta overrides. Remember, these are the only two conditions where two healthy ventricles are putting blood into only one artery, which is the common arterial trunk or the aorta, as in CAT1 or in PAVSD. There is no second artery to share the ventricular pumping. In all other conditions, there is a second artery which can share. In a PAVSD and a CAT type 1, both the ventricles are healthy, both of them are pumping well, and they are pumping into one vessel. There is no second vessel to share. And that is why, the largest arterial trunks in an overriding artery occurs in an overriding aorta, occurs in a PAVSD, occurs in a CAT type 1. That's a useful thing to remember. I showed you how large it was in the PAVSD that I showed you. 3 vessel view, a huge, humongous arterial trunk.
Yeah. You're connected to the right Wi-Fi, no? There is a lot of lags in between.
Yeah, all through I've been with the same Wi-Fi.
Okay, okay, fine. Few more. Sir, can you explain case of Taussig-Bing DORV?
Taussig-Bing DORV is a DTGA type. I showed you a case also where the aorta is anterior to the right of the pulmonary artery. Normally, the pulmonary artery is anterior to the aorta. Here, the aorta goes anterior, pulmonary artery comes posterior. So there's a transposition. It's a detransposition because the aorta is to the right of the pulmonary artery. And also, this is associated with a pulmonary stenosis and a subpulmonic VSD. So therefore, the combination of a DTGA relationship of great arteries, a pulmonary stenosis, and a subpulmonic VSD is called a Taussig-Bing anomaly. That's it. Okay. It was described by a cardiologist called Taussig. I think Taussig is a lady, and Bing is a gentleman. Yeah, who was a cardiothoracic surgeon. Very interesting to note. I have got a full article about how Taussig and Bing, cardiologist and cardiothoracic surgeon, acted. It's a very interesting interaction. Yeah, as co-workers, not only for this anomaly, working in the same hospital, looking at the same patients. That kind of a working arrangement is very interesting. Makes very interesting reading.
Okay. We sometimes see artifact close to aortic valve. How to differentiate between artifact and true perimembranous VSD?
Artifact is above the valve. True membranous VSD is below the valve. So mark the valve and make sure that the so-called perimembranous VSD is below aortic valve. That is more towards the apical side of the aortic valve, whereas the artifact normally is towards the cephalad side or the distal or the downstream side of the valve.
Similarly, how to differentiate between coronary artery ostium and VSD on LVOT view?
Same. The artifact generally is touted to be due to the coronary ostium.
Okay. I think we've covered all. There's one last question. Sir, will you be watching football match today? Just curious.
I will only look at the news tomorrow morning and the papers tomorrow morning to see what Morocco does to France. Morocco has had a fantastic run. Fantastic is not the word. And I think an African team reaching the finals is going to be a shot in the arm for the entire continent of Africa as far as football goes. But I'm not going to burn the midnight oil. No. No, who's going to do my cases tomorrow? I can't leave it only on Rachita.
Yeah, please don't. There are a lot of films coming tomorrow. I think we've covered all. Thank you so much to Dr. Vivek and to all the others who sent me screenshots of the chat section, because we are not able to view the YouTube comment section for the questions. I'm sorry if we've missed any, but I've covered everything that I've received on the screenshots. A lot of comments saying excellent talk and thank you very much.
It's always with us, sir.
Thank you, Dr. Sanjay Desale. Thank you. And I can never forget the wonderful trip I had to Nasik and the way you organized my visit to Shirdi. I'm very, very grateful to you.
It's my pleasure, and we are always waiting for you, sir.
Thank you so much. Thank you.
Again in August, sir. Again in August.
Okay, done.
Imagicon,
isn't it? Imagicon is your brand name, correct?
Yes.
Dr. Barve had written to me a mail. Dr. Vijay Barve.
Yes.
Wonderful. Thank you all. A wonderful, very active group. The Nasik group I always admire. You really put education in front of everything else, and it's a very lovely feeling to work with y'all.
Yeah, there's a pan-India audience today for your lecture, sir.
Oh, thank you so much. Thank you.
Yes, thank you, sir. Thank you very much.
Thank you so much, sir. Thank you is a small word. It was a great marathon session today. I thank MCR for organizing this activity for us. I thank you, Fujifilm, and thanks a lot, delegates also. Thank you, Rachita ma'am, for being there.
Oh, please don't call me ma'am. Thank you so much. It was my pleasure, and I'm so happy I could get a few questions from the screenshots. So I hope most of the attendees got their questions answered. But thank you for putting this together. It was really lovely. Thank you so much.
Thank you, and bye-bye.
Thank you.
Bye.
Good night.
Thank you.